Good day. This is Charles Denham, and I am welcoming you to the TMIT High Performer webinar series. And today our topic is Leading Through Crisis, from the Fog of War to the Triumph of Leadership. We'd like to welcome everybody on board from across the country, and actually we've got folks that are global from around the world. We'd like to, I'm on slide 3. On slide 3, you'll see an image in the left lower hand corner of your screen. You'll see an icon for a telephone. If your audio is not coming in strongly and having difficulty after you turn up your volume, go ahead and click on that, and then our team will help you get a separate line. Slide 4 is the landing page of our website, Safety Leaders. And at Safety Leaders, if you go up into the What's New section, you can click on having the opportunity to access the webinar page. And the webinar page for today has the topic, as well as this will be the place where a number of resources will be posted after we're done. And if you'd like to come back and listen to the audio and watch the slides, you can. On slide 6, and you may download slides today in a PDF format and then be able to come back and watch the webinar at that time as well later. On slide 6, reminding you about Twitter and Facebook. On slide 7, that our calling is at TMIT is to save lives, save money, create value in the communities we serve. On slide 8, we have our disclosure statement, and we've got some wonderful speakers today, so I'm moving quickly and would love for you to read the full disclosure statement. However, no products and services will be discussed today by any of our speakers. And then we have our disclosure statement. I'm on slide 10. And I'd just like to address the folks whose pictures are before you on slide 10. We have Tom Emmerich, who is a consultant to the self-insured purchasers of health care in the United States, and I'll go through his bio as I introduce him. John Nance, one of our quality and safety leaders, a global leader, as is Kathleen Bartholomew, and both they're married. They are a great double team, both in the boardroom and at the bedside together as we look at health care. We have Michael Williams, Dr. Michael Williams, who is the president of the University of North Texas Health Science Center and has a number of colleges reporting to him, a former hospital CEO of who we've worked with for a long time, who will be addressing leadership and really the triumph side of leadership. And we have Terry Wheat, who's a nurse. She is a chief leader, a clinical leader with all clinical duties reporting up to her at Shriners Hospital in Chicago, and she's also on the board of Sinai Health Systems, along with Sharon Rosemark, who at last minute had to cancel because of her own healthcare crisis of her father, and so our prayers will be with him. That was just to get him in for some treatment, but as we all know, it's very busy and difficult to do that. And Becky Martins, our patient advocate, who will share an inspirational message with us as we get started. So now I'd like to introduce Becky Martins, and as we do with all of our webinars, we have the voice of the patient to really ground our hearts, our minds, our souls, and what we're about to do. This isn't just education. These are families that are depending on us to do a good job. And so Becky has been a longtime patient advocate after events that have occurred in her life with her father, and in her life has been just a tireless champion for patient safety, has been a co-author with us in articles in the Journal of Patient Safety, and she's also was the co-author of the chapter in the National Quality Forum for patient engagement, which we were honored to have National Quality Forum allow us to put in the last 2 updates. So Kyle, please roll the tape for Becky.
Thank you, Dr. Denham, for inviting me to be part of today's webinar. No one wants to see caregiving organizations succeed more than patients and families. By embracing partnerships with patients and families, caregivers can improve the reliability of the care process, improve patient experience scores, and most important, save lives. I'll turn the call back over to you, Dr. Denham.
Great. And so I'm going to set some of the context and give you a little bit of a background as to why we're addressing this issue of leading through crisis. And these two graphics we're going to be using for a certification course and for future webinars to address the critical issue of crisis. And we've experienced that in the last year. We've seen it institutionally, personally. We've seen it with a number of the patients and families that we work with. And it's very interesting as you look at the fog of war that sets in after a healthcare accident or a crisis of a business crisis, a personal crisis, or any kind of crisis. We're in the fog of war. We don't make good decisions. We don't understand what's happening. We go through, as what my pastor would say, we go through a shock period and a struggle period, and then we get grounded in what we need to do to get the job done. So as we go through this, and after an event, we go through the fog of war where there's great risk, and there really aren't good best practices at leading through a crisis. There are lots of people that talk about crisis management, but we don't need managers at the time of a crisis. We need leaders, and leaders have to take certain risks to the benefit of those that they're caring for. And after these bad events occur, there's a time of healing and a time of growth. So we're going to take this full continuum as we go forward, but today's objective is really to address multiple crises. I'm going to introduce Tom Emmerich in a minute, but Tom is really going to give us a good feeling for what's going on the national scene. Frequently, we are so inundated with our own clinical and operational and patient safety issues that we don't realize that there are others out in the ecosystem, in the marketplace, that are starting to realize this is a big crisis. It is a growing crisis, and things are about to snap. And we're going to ask Tom, who's the great author of Cracking Healthcare Costs, and you see his blog there, as a former HR leader who actually works very closely with the self-insured companies to address this critical crisis. We will then have John Nance, who is one of our wonderful, just a treasure to us at Patient Safety and Quality, address the crisis in the boardroom and what's happening now. We've all talked about the fact we need to get leaders in the boardroom and we need to get people engaged, but it starts to sound like old news. And yet this crisis is getting worse now as folks are really focused on getting their networks together, patient experience, and aggregating these large networks. And patient safety sliding down the scale and even off of the top page. And we're going to have John address that and what's going on today. Kathleen Bartholomew is going to address, and I'll introduce each one of them, but she'll address the crisis at the bedside. So there's the national crisis, there's the crisis in the boardroom, there's the crisis at the bedside, and also a best-selling author and a nurse. She will take us through what's going on now, right now, at the bedside that she sees. And I think the benefit of these three great first speakers are they're telling us what's going on right now, not a year-old data, two-year-old data, because they're engaged with these leaders all the time. And we just finished 3 wonderful days with Dr. Mike Williams here in our California office addressing leadership issues, and a critical care doctor, anesthesiologist, former hospital CEO, who's now leading a multi-school, multi-college healthcare institution in the Fort Worth area, and he really can give us some highlights as to how they went from being, as a hospital, below 4,000 to #1 in the eyes of CMS, and how they did it. Now, what I'm going to do to establish the framework here in the first few minutes, we pulled the definitions of crisis, leadership, and management, and we've been pulling literature searches on crisis and on leadership through crisis and crisis management. And the marketplace is woefully inadequate to help any of us that are truly going through what we would call a real crisis. And so these definitions from Oxford Dictionary really don't nail it. Intense difficulty, trouble, or danger, yes, that's true. But hey, listen, when a crisis hits and you've got multiple deaths from a patient safety event or a major PR crisis or a major crisis of conflict of interest, and the predators, the press, and everyone are attacking, the fog of war is very difficult time to make good decisions, which John will share with us as a pilot. When a crisis happens in the cockpit, without the training and the best practices, we have a problem. There's a real difference between leadership and management. Management is kind of keeping things going, but leadership is really taking the bull by the horns and having to really deal with a crisis the way Sully Sullenberger did, which I'll address in a minute, when he landed on the Hudson, because what he did in 205 seconds is really what we need to do through those weeks or months of a crisis. These are the types of crises that come from multiple texts. On the left are the types that you see in crisis management books. We'll talk about natural and unnatural disasters and the various kinds of crises that we see in business or personally. But for us, the up close and personal crisis is when we have a healthcare accident and we've harmed someone, or we're attacked for harming someone, or even internally when our own organization or our colleagues attack us for a system failure and we don't even know that we've harmed anybody or wrongdoing has occurred. The issue of misdiagnosis is just coming on the scene and people aren't talking about it as a healthcare accident. You'll hear from Tom, this is a healthcare accident. The misdiagnoses that is occurring, that's crippling our country in terms of cost, we don't even think about in patient safety, and it's an enormous problem. Intentional harm is very small but very important. Conflict of interest, allegations of impropriety, false allegations of impropriety, that's a crisis for caregivers and leaders, and we've seen that, and we've personally experienced that. The lynching of patients and caregivers after something bad happens, when lawyers are brought in to make the family feel like they were part of the harm, or a caregiver is thrown under the bus as organizations try to protect their paycheck by vilifying the victims, the first victims, the second victims, and even the third victims of their organizations. Identity theft, patient record theft. We're losing 20,000 patient records a month now that are being stolen, and people are submitting tax returns on behalf of people whose identities have been stolen. So this is an issue that Mike Williams and I have been working on, the triple healthcare crisis burden, because he's now leading a higher ed organization. And Tom, as we talk with you, there's an employer crisis, the exploding healthcare costs due to overuse, underuse, and misuse of diagnostics and therapeutics. Direct costs, we see those, cash, but the indirect costs of presenteeism and absenteeism and aging families, and we've sandwich generation and taking care of our elders who are, of which 180,000 are dying in our hospitals because we're not doing a good job. The provider crisis is the failure to deliver safe and high-quality care, as they have to move from a volume incentive to a value incentive. And John will tell us it's hard to build an airplane while you're flying it, yet that's what's happening. So there's a crisis there. And then for people like Mike, the healthcare education crisis. He leads a medical school of 920 medical students. He's got public health school, a pharmacy school, a physician's assistant school, and these healthcare learners are having to learn the old stuff in order to satisfy graduate, postgraduate, CME, licensure, and maintenance of certification, and yet no one is teaching them how to satisfy Tom Emmerich and who he serves, because we're teaching the old stuff, and we almost have no real solid curricula in patient safety and the cost of patient safety and how to reduce it. So in the article that John and I wrote with Sully Sullenberger and Dennis Quaid, we addressed the critical need for the NTSB for healthcare, that we really need to understand the breakdown and then make that public and apply that. And when we worked with Sully and we talked about these bad events, like the one when the drug mix-ups caused the deaths in Indianapolis, it's not unlike what happened to Sully in 205 seconds. When Dennis Quaid and I asked Sully, what did you do now that you've reflected on it? He said, I did three things. He said, number one, I enforced a calm on my terror, a physical calm on my terror as the leader of that airplane. Number two is I put a structure on the chaos that was going on. He applied a structure that he had learned to the chaos because of the fog of war. And then the third thing he did was he did what he knew he had time to do, because the simulator had trained him that he only had about 200 seconds to do certain things. And I had the chance to talk to his co-pilot at a social event that Sully hosted for some of us that had helped him. And he said, listen, Sully did some things that weren't even in the book, and I just took the book. So training and simulation and having best practices when these bad events occur. And now I'm going to go through two or three of them quickly before we come to Tom. But the Julie Tao story of 4 system failures that led to this nurse being involved in giving the wrong medication to a patient and then being thrown under the bus and criminally indicted for what any one of us who was fatigued and had 4 system failures that were a stacked deck against us, almost none of us would not have made the mistake that Julie did with fatigue, with a barcode system that wasn't working, with a workaround that had been established to help the doctors, and the fatigue being a major contribution, and then identical connectors for the medications that she was giving. So, and we put that in the Chasing Zero film. Interestingly, the issue that happened with Dennis Quaid's newborn babies, where they were given 1,000 times the dose that they should have of heparin twice, both babies, Dennis and I were preparing another film, our second film, when we were notified while we were shooting it that this event was still occurring. And it had occurred in Indianapolis 11 months before it did with his twins, and it occurred the day we were shooting after. So had we fixed the problem of just these labeling issues that were system failures, the outbreaks of hepatitis, these large-scale outbreaks are an institutional accident as well as an accident for each one of the patients, as well as an accident where we have to take care of our caregivers. We know this Las Vegas was highly celebrated. And CDC, who we've been working with, has told us there are a number of these broad outbreaks. When we think of the Emily Jerry story, when a little girl was given chemotherapy and the pharmacist that was in charge was also criminally indicted and went to jail, who we put in the Surfing the Healthcare Tsunami film, we're still at that point, and Tom and John and Kathleen and Mike will address the fact that not only is it still happening and it's worse, but leadership is the answer. And we're also seeing this with our own healthcare system, that people around the world are looking at us and they're seeing this kind of data. I'll close with just a few more slides that Tom will build on. But now our press is replete with a number of the studies we're now seeing of misdiagnosis, which you as safety and quality officers, the majority of you in our audience are, you are going to have expanded accountability and responsibility for things that we didn't typically include in patient safety, like misdiagnosis, which is on epic proportions. The number of diagnostic errors in major diagnosis is 10 to 30%. We're seeing the same kind of pattern with overuse of high-tech imaging studies and then incidental findings that lead us to overuse therapies. So this battle that we're seeing is being played out now in the boardrooms of our large corporations, which Tom will share with us. This paper on slide 32 is a great article, and this article addresses the patient-initiated second opinions, the need for these. And I'm seeing this over and over and over again, that people now realize that misdiagnosis is enormous. Our fragmented healthcare system is demanding that we be better at giving second opinions and be gracious about helping our patients get second opinions, and that patients and families are going to need to do it. This article, The Bitter Pill, the 26,000-word article in Time magazine, says it all. It's, I think, a must-read. This is something you can take in the boardroom. It's recent enough to have real impact, and it really addresses a lot of the key issues that are at play that have not been addressed, and now we're at a breaking point. So it is a crisis. Now, the good news is we are moving from this volume-driven marketplace, or the first curve, what Ian Morrison would describe as the first and second curve. Our opportunity to innovate is right there at this intersection where the chaotic, this is almost the 205 seconds played out in 205 months of what happened to Sully. This is your opportunity to innovate, but not just play the same old record of medication errors, and we're going to cover this and that because that's what we've always done, but addressing more broadly these critical issues. The last 2 webinars, I put this slide up. I want those of you that have come on and haven't seen the last couple of webinars, this study by ARC was critical, and it showed 37% of folks in our hospitals, 1 in 5 hospitals were surveyed, 600,000 employees, and they're still afraid of reporting an error while it's happening. So now as I turn to Tom Emmerich and ask him to frame for us the next 10 minutes, we're going to ask him to really frame from his view the national crisis, not 2 years ago, but what he's seeing today. What, Tom, are you seeing today? Now, Tom was the head of HR for Walmart. He's worked with the largest corporations in the world. He's a trusted advisor. He's written a terrific book that we all need to read and reread about cracking the healthcare cost. But today, Tom, if you could tell us what's going on in the corporate environment and how big a problem is it? Is it getting worse? And what can we tell our bosses? Because you know you're preaching to the choir. Tom?
Right. Dr. Denham, thanks for the introduction. What I'm going to do today is spend some time describing a rapidly emerging issue in patient safety. I work with a lot of big companies. Not all of them are aware of this right now and looking at it, but the ones who are leaders are. And the leaders start addressing this, there'll be a flood of it in the future. So what I'm going to talk about today will become a gigantic issue over the next 5 years or so. A way to characterize healthcare in America today, there's several ways you can do it, but a way is there's a very large amount of misdiagnosis happening, a massive amount of over-treatment, a massive amount of unnecessary surgery. Payers are becoming ever more aware of that, partially through the media that Dr. Denham described. These things are showing up in the Wall Street Journal, New York Times, etc., Time Magazine, and it's a critical issue. Now, around 40% of benefit plan dollars are spent on patients who've been seriously misdiagnosed or been given a seriously flawed treatment plan. I'll cover that a little bit more in a couple of minutes. Further, the U.S. definition of quality needs improvement, and frankly, it's out of step with our peer countries. In benefit plans today, this is true for insurance plans as well, 6 to 8% of the enrollees spend 80% of the dollars. Of those outliers, these are people with complex conditions, 10 to 20% have been completely misdiagnosed. Another 40% have deeply flawed treatment plans. Now, and the Mayo has studied this, and what they say about this is these aren't minor misdiagnoses and minor treatment plan errors. These are ones that actually affect the patient prognosis. Now, these are complex cases. People don't misdiagnose a sprained ankle. They don't misdiagnose a cold or the flu. But in the world of these outliers, are typically seeing 3 or 4 specialists, and the specialists are often failing to coordinate with one another. An example of that is there are people going to an eye doctor for chronic eye inflammation, a heart doctor for periodic heart palpitations, another doctor for severe back pain, and another doctor yet for malaise and fatigue. All 4 of those, seeing 4 specialists, and I've seen that over my career over and over. They're being seen by 4 different specialists who are examining them and prescribing treatment for the symptoms they see. But all 4 of those conditions are symptoms of a disease called ankylosing spondylitis, which is easy to treat with a $20 a month prescription, $10 a month prescription from Walgreens or Walmart. But they're not getting that kind of diagnosis. It's going to be an increasing problem. Among health systems, there are extreme variations in this. Some health systems do a very good job about getting the diagnoses right for outliers. The Mayo Clinic's an example. Virginia Mason's another example. There's others, but some of them systematically and through processes get it right, while others have a very high rate of doing it poorly. Also, same thing with treatment plans. There are centers around the country that do a very good job of getting the treatment plan right, and there's many who simply don't. Now, one thing I do for employers, have been doing for the past few years for major employers, is helping identify the centers that do it right and doing direct contracts between them for them to send their employees to these centers directly, going right past the blue United cigarette and insurance, to send into these centers for things like hearts, transplants, spine surgery, orthopedic surgery. And very high percentages of the people that go to these centers have been told to have knee surgery. About half of them have been told to have knee surgery and go to these centers. It's discovered that knee surgery is not indicated for them. With spines, it's even higher. With transplants, it's even higher. They're giving transplants to people who's just simply been misdiagnosed. That's a tragedy for the family. The patient getting this is a severe victim. And it costs the benefit plan about $2 million over 5 years. And this situation is actually worse today than it was 20 years ago. The rate of getting these things wrong is happening at an ever faster clip. I'll give you another example. And this is something everybody needs to be keenly aware of, because you're going to start hearing about this from payers very, very soon. Some of you are probably already hearing about it. In new cancer cases, between 10 and 30% of new cancer cases have been misdiagnosed. They either tell them they have cancer when they don't have it, or they've misidentified the cell, large cell versus small cell, the treatments of which are completely different, or the site of the cancer. It's actually worse in some women's cancers, but let me go on. There's another study done when they gave radiologists images to review, images that had significant findings. They diagnosed them all. They gave the same images to the same radiologist later without their knowledge. They changed the diagnosis on them about 34% of the time. That is extreme variation and puts patient safety at deep risk. Now, radiologists are human. We're all human. Humans make mistakes, but not on this kind of scale. If it's going on this kind of scale, something's really wrong. One is a lack of, there are two big causes to this. One is lack of standards in reading images, but it doesn't have to be that way. Some hospitals and health systems are getting images read and getting them read correctly through methods. Virginia Mason's a great example of it. I visited them a couple of times. I've helped them do direct contracting with employers. They have processes in place to make sure those errors don't occur. One center on cancer cases, pathologists are making a lot of errors reading cancer slides. When somebody comes there for a cancer review, they have two pathologists read each slide independently. If they agree, they call it. If they disagree, they send the slide to the Mayo Clinic for a tiebreaker vote. They want to get cancer diagnoses right. The other big way this happens is simply lack of accountability. The best systems in the world, somebody's reviewing the work of the specialist, the pathologist, radiologist, to make sure they're reading slides well, reading slides and images well. That happens in a relatively small percentage of the systems in America, sadly. The U.S. has an unusual definition of quality. And I've run health benefit programs in other countries, in Canada, UK, Germany, Japan, Argentina, Brazil, Mexico. And I've studied the health systems in other countries like Australia and New Zealand carefully. The definition of quality in America is changing rapidly. The old definition was care delivered to a gold standard. That sounds good, but it's flawed. The new definition is that the right care is a diagnosis right and the treatment appropriate, then is it delivered to a gold standard. And a top benefit executive in a Fortune 50 company recently told me the first definition of quality is, are they diagnosed right and are they given the right treatment plan? Everything else behind that is subsidiary. And his company is taking steps to help ensure this doesn't happen to their employees. Again, these things can be done correctly, but oftentimes they're just overlooked. I want to talk about a new ethical dynamic. I'm not saying, one, that people are unethical in healthcare, but there's an ethic and there's a higher ethic. Under the prevailing medical ethic in America, we say if something might help somebody, let's do it. That sounds reasonable, right? But we made it the only English-speaking country that uses that definition. Others use the definition something like this: first determine what the desired patient results are, and then use the safest, least invasive way to achieve the patient's goal. We're doing heart surgery on patients today that will have the same 5 and 10-year survival rates if they were simply treated medically. In other countries, those patients are treated medically. In the U.S., they're getting a heart surgery with all the risks that go with that. When medical treatment's the right course of action, and that's what's driving companies that I work with to do centers of excellence, because they like to send people to places that don't do unnecessary heart surgery on their employees, and don't do and get diagnoses right. Many later days are realizing that the error in diagnosing, the error in treatments, and saying that's the ultimate quality failure. By the way, the death rates in hospitals, that's a relatively narrow variation. And it might be a variation plus or minus 2% or 3%. The variation in getting the diagnosis right is plus or minus 10%. And the variation in getting the right treatment plan applied, I mean, the treatment plan that enhances the patient prognosis is plus or minus 20%. We've typically been concentrating on the narrow variation and ignoring the huge variation. And frankly, that's changing. And it's changing rapidly, and we need to be prepared for it. Well, that concludes my part of the presentation. I'll be happy to answer any questions or take comments about this at the right time. Thanks, Dr. Denham.
Great. Thank you so much, Tom. And I know we'll have some good interaction, and thanks for being brief so that we can have that interaction. That's a great highlight, and I think the takeaway is the problem's bigger, it's getting more prominent, and these new areas are going to be the responsibility of safety and quality folks. I'd like to shift gears now to invite John Nance, who's on board with us, and he's been featured in our films in the past and has been just such a great asset and really a treasure in patient safety. His bio would take the next 30 minutes to read. Suffice to say that he is a multi-talented individual. He was in the military and a pilot in the military. He's been a captain of a major airline. He has a law degree from a great law school. He is a current safety expert in the media in both areas of aviation and in healthcare, and I think above all, a man of great honor and dignity and focus on values, and a constant and vigilant warrior in this battle of in the boardroom of getting leaders to understand why it's so critical to take action. And John, you've spoken on our behalf and for our audience a number of times. What we'd like to know, and have you put into context for us, what you're seeing today in the boardroom, any insights you can give our audience on how to get the message across that this isn't the usual old patient safety issues. We've got bigger issues, more problems, and we can't let patient safety slide off of the top 5 list the way it is. And give us an insight and a peek into the boardroom today. Thanks, John.
Absolutely, and good to be with everybody today. I think one of the things that comes to mind here, and everyone knows I'm from the aviation industry originally, is that we wouldn't have an airline industry. I mean, we wouldn't have had an airline industry for the last 25 or 30 years had we not finally had all of senior management and all of our boards, and of course these were for-profit corporations, finally get the point that they had to do something, and they had to do it fast in the 80s. I won't bore everybody with a long recitation of what was needed, but basically the revolution in human factors that created a situation where we could go for 12 years without a major accident in the United States, which we just achieved up until last summer, was a direct result of boards getting involved. Now, the problem, of course, in the differential model with the hospital and medical world is that most of our boards are most of our organizations are nonprofit, and the boards are volunteer. And in time immemorial methodology, it has been that the board members on most hospital boards are fine, upstanding members of the community trying to do their turn at the wheel. But if they know anything, it's money. And we can't just do it that way anymore. So one of the problems is that, and I know this from everybody who's listening here as safety professionals understands the agony of seeing things that need to be done and not being able to get people to listen, whether it's in the C-suite or above. But the fact is that you are teachers and proselytizers, and basically the information that you have on not only what needs to be done and when it needs to be done, but how it needs to be done, and on the magnitude of the problem, is something that most boards are completely ignorant of, not because they're stupid people, but simply because the way we've always done it, which, by the way, is the most dangerous phrase in medicine, has obscured the fact that we cannot just move deck chairs around on this sinking ship anymore. We're going to have to either patch the hull or change to a different vessel, because we're not going to make it if we keep on the way we're going. 440,000 deaths. Let me just forward, if I can, the slides here. And these are just normal boards that you see every day in American hospitals. But this is a paper that came out last year, Dr. John James. 440,000 completely avoidable deaths annually in American hospitals, half from medical mistake, half from nosocomial. You all know this. By the way, that paper has not been attacked. It's been supported. Over 4 million injuries from the same cause, according to Dr. James. Now, the thing is this. The traditional focus of governance boards has always been just the task, as I say, of keeping the money flowing. And most board members do not realize the depth of the crisis. And that's where education is desperately needed, both formal education for the board and for governance aspects, but also as much information as they can get from you. And yes, I know that this has to run through the C-suite, and there are some CEOs who want to keep their boards rather isolated from, and that's being charitable, from what's really going on. I think that's a very great minority, or a small minority. But the fact is that the boards have the final authority. Way back in 1965, the Supreme Court of Illinois decided a case that many people know about called the Darling case, that said that the final responsible group in anything to do with medical negligence is the board of directors or the board of governors, or whatever it might have to be characterized. And that has been widely ignored for a long period of time. Now we are in the beginnings of a major board revolution. And the need for education, the need for knowing what you know, the need for being able to bring them into even programs like shadowing and to structure things to where they've got an opportunity to really see what's going on is absolutely vital. The sacred trust of assuring the public that an institution offers only the absolute best that medicine has to offer, and in accordance with best practices, very much what Tom was just saying. We're so wide of the mark on that. And it really pains both Kathleen and myself when we hear people say, oh, we're in a financial crisis now. We don't have time to worry about patient safety. We'll do that next couple of years. But you're not going to keep the doors open if that's going to be the attitude. And the board mostly does not understand this. The board education that we have done over and over again has seen jaws dropping when they see the magnitude of the problem, when they begin to understand what it takes to change a culture. And all of these things have been hidden because it was not the normal province of the board. The collective and individual responsibility of the board for due diligence far beyond the traditional board review of reports and summaries is something never ever contemplated by tradition. Yet the very form of the board of directors, and whether we're profit or nonprofit, absolutely demands that kind of scrutiny and accountability. Consider this reality. Were there essentially no deaths or significant injuries from medical mistakes, nosocomial infections, versus 440,000 a year, and if there was no pervasive evidence of overtreatment or undertreatment in American medicine and American hospitals, versus emerging proof of massive overuse and underuse and unexplained variation. And if the value and the quality of medical services provided by healthcare institutions were well balanced and not grossly out of proportion to the medical services in the rest of the industrialized world, then there would be little or no need to improve strict accountability for medical matters and to put that on the boards. That, however, is not the world we now live in. Just as Tom was saying, and with the C-suites increasingly unable to significantly decrease unnecessary harm or provide the highest standardization of best practices, our society has only one place left to look for rapid improvement, and that is the boardroom. That's why this is so important. And yes, I know that probably the vast majority, if not all of you, can't just turn around, pick up the phone, and gain the board's ears and start working on it. But you need to know that everything that you can do to enhance board education and board involvement is going to be vital. The board is not just the final authority for assuring the public of the highest level of compliance and quality and safety. They are and should be accountable themselves. And as a matter of fact, that is a very important point, I think. President Reagan had made this phrase very well known during his time in office. Trust but verify. It was actually in regard to the old Soviet Union, but the phrase has applicability in most human endeavors where the stakes are high. And medicine is the poster boy of this. We may trust our CEOs and our C-suite, and certainly we do and we want to, but that trust does not remove what at least one U.S. senator wants to make the individual and personal accountability for providing best care. In fact, if Senator Charles Grassley has his way, we're going to see Sarbanes-Oxley extended to health care. And for some reason, I'm not being able to get this next slide up here. Let me try that one more time. There is the gentleman. He's actually been on about this for some time, and I think he's eventually going to succeed. And whether you like the idea or don't like the idea, Sarbanes-Oxley compliance is what has been revolutionizing for-profit boards around the country in terms of the accountability standards. And there are significant individual civil and even criminal penalties attached to that law. And you know, we're not trying to throw people in jail, but here's the thing. We are not performing at acceptable standards by any reasonable measure. And today's CEOs and associated chiefs are typically too overwhelmed with the day-to-day guidance of the institution from a tactical and to some extent strategic point of view to have much involvement with setting the standards and setting the philosophy and absolutely assuring to the public faithful and trustworthy compliance. And as we see, and as Tom just told you, we are so wide of the mark for faithful and trustworthy compliance with the best that medicine has to offer that it literally is almost approaching the point that if the American public found out what we all know, they'd be lighting torches and marching on their local facility with great anger. So what needs to change? In terms of boards, first, I think it's very important, and I found this lurking around nonprofit law and governance for dummies. It's almost the need for something that basic. Board members and trustees, first of all, have got to be selected for their skills relevant to guiding a medical institution. And no, you may not have the definitive voice on this, but you can contribute, because all of us in communities have a voice to a certain extent, and we really have to do this. Board education cannot be optional, and board education includes education on what's going on the front lines, and that's why board shadowing and other programs for familiarity of the front lines are vital. Let me tell you one of the things that is absolutely excellent. We have so much information on a daily basis emanating from the front lines. It doesn't have to be when there's a simple event, but when there's a near miss or when there's just apocryphally somebody saying, we had to do a workaround. If we can't mine that, if we can't understand how that works compared to, for instance, the brilliance of the National Transportation Safety Board system, we're never really going to get this right. And let me tell you about the NTSB in a nutshell. The basic idea is blame is immaterial. The basic idea that anything goes wrong is a message from the underlying system. If you can take it apart, if you can find out all the elements that contributed to whatever didn't go the way you wanted it to go, and if you can attack each and every one of them without worrying about blame, then you can very rapidly learn those lessons, incorporate them, and build a better system. Now, who really has the impetus to make sure that that's the ethos of the organization? You're right, the board of directors. And that's why this is so vitally important. And in retrospect, there's only one way that we're going to be able to clean up this massive problem, which has resulted from two things. Number one, a cottage industry that is hung on as a cottage industry when it simply cannot handle the complexity of American medicine today. And secondly, the fact that the profit motive has skewed everything around in different directions and has made us very confused as to what is and what isn't the most important element. To give the population absolutely what they have a right to, which is the best medical care that medical science can provide, coordinated, standardized, and administered as broadly and as efficiently as possible, we are going to have to change a lot of things. And those changes cannot always be instituted, even with the strongest C-suite, the strongest CEO. The board has to become involved. Without that, we will end up with this non-system, as George Albertson once called it, completely collapsing, and we'll have to put it back together again. Thank you very much, Dr. Dunn. Appreciate it.
Great, thanks, John. And you know, I think the takeaway is that we don't see the receptiveness of the board any better than it has been, and I think we're seeing that it's worse, and we really need to get that message into the boardroom. And a lot of our audience feel frustrated they can't get it there. So that's what we're going to be working on going forward, is to figure out how we can get those messages into the boardroom. I'd like to shift gears now to have Kathleen tell us what she's seeing at the bedside today. What is the crisis at the bedside? What do we need to know, and what do we need? Again, we're preaching to the choir here. What can you share with us, Kathleen, that we can apply and know about at the bedside and this crisis there? And then when we finish with Mike Williams, we're going to hear about how, with very little resources, he was able to marshal the nurses and the doctors and the board together. So, you know, it's kind of negative to think of all these difficulties, but I think there are some highlights that are around the bend. Go ahead, Kathleen. You've got a background as a consultant, as an educator, as a frontline nurse working with great leaders across the country, and I've written a number of books that have had real impact at the bedside. Would you please take it away?
Absolutely, and thank you. I appreciate the opportunity to share what I've learned today, especially about the culture at the bedside. I'd like to start by that point that you brought up earlier, talk about patient safety sliding down the scale, and about the culture of fear that we have in hospitals. It's very disconcerting to think of that almost 40% of staffers would not, report an error, and that goes so against the grain of first do no harm. It's really hard to understand, and my goal today is to help understand, how this culture came about and why people are not speaking up to keep our patients safe. One of the reasons is that a lot of our efforts in patient safety, not everyone, but a lot, have gone into the processes. For example, barcoding, which is fantastic, safety cuddles, which are fantastic, and passports to surgery, etc. But what is culture? Culture is what's happening when management's not there, when the quality or risk person is not walking on the floor. Let me give you some examples. I walk into a hospital at 7 o'clock in the morning. A nurse is complaining, and I said, "What are you complaining about?" And she was complaining about the barcoding, which I couldn't understand because I would feel so supported by that. But I asked her what the problem was, and she rolled up her sleeve, and there on her arm were 8 of the bands of the patients that she had printed out to, quote, make her job easier. Another example is I call a hospital CEO. 2 people have died in the last few months, and I said, I'm available. Is there anything I can do to help? And her comment was, we just don't have money in the budget for a patient safety initiative right now. I suggested to her that she never do a patient safety initiative. That patient safety was not an initiative. It's a goal. It is a value as demonstrated by leadership. So I think that we need to understand how powerful culture can be. There is actually nothing more powerful in any institution. It's like a fish talking about water because it's all around us and we don't see it. I recently visited a hospital where falls were a problem. They recently had 2 falls with injuries, and I said to the chief nurse, let me just walk around the floors for a few hours and I'll be back to you. After a few hours, I walked into her office and said, you don't need to hire anybody. I said, from my observations walking around the floors, people thought I was visiting. So every time they had a free minute, all I saw was every one of your nurses taking out their cell phones on Facebook, on Twitter, they weren't using them for work. They were using the computer and the cell phones. Those precious minutes where they used to check on their patients, they're now accessing, their personal email. So you just have to enforce the rule that you have. And that rule is, of course, that there is no personal calls and your cell phones stay in your locker. It's important for us to ask why and what is stopping employees from speaking up. And I was fascinated by that. So what I did is I did an informal study of more than 5,000 healthcare professionals and asked them why they weren't. And these are the number one reasons why people are not speaking up, why that almost 40% are not saying anything. A fear of retaliation, and the retaliation that is most frequently experienced is getting a bad assignment or somebody refusing to help me or being fired or having a bad performance evaluation. And you can see the rest of them. They're all fear-based except for no time or why bother, which is an example of learned helplessness. This is really important for leadership because how you lead a fear-based culture is different from how you would lead other types of cultures. What we know about a fear-based culture is that in order to change that, our patients aren't going to be safe until the caregivers are safe. So the first thing to do is to make sure that all the caregivers are safe, and how we do that is by creating safety for our leaders. As Simon Sinek says, leaders create the conditions for trust and collaboration. And when people are not speaking to each other, when they're not having direct communication, assertive communication, then what we see is an increase in overt and covert behaviors, because when they're not having the conversation, this is what human beings resort to. It's not, this is not something that's new, and I know that if you're in safety then and quality, you're aware of the silencekills.com studies. But what I'd like to point out is the finding of Dana Jack, which says that when she dove into the reasons why people weren't speaking up, and we know again and again that communication is right up there with keeping our patients safe. It's the fabric that we weave with our words that's going to be the safety net that catches all of our patients. She found out that they had a different value system. So if our education isn't getting down to the level of what we value, she found that people value the relationship with each other more than they value anything else. And I guess I can vouch for that, because when I travel around the country, I ask the audiences, if your cell phone went off right now and the person you love most in the entire world was admitted to the place where you work, could any nurse take care of them? Could any physician or surgeon do surgery? And the answer is no. And it's not a lot of people. It's only usually one or two people that they say, no, that person can't. And here we have cognitive dissonance. When things don't match, this is what human beings do. And in order to really create patient safety, we have to value the patient more than anything else in the world and stop traveling in that school of fish. The problem is we don't understand ourselves as the social animals that we are. You talked about that time that we have for innovation and for change, those precious 250 seconds and months, etc. And what we know about innovation is that you can't have innovation unless you have diverse opinions, people speaking up, and what we call a positive deviance. Yet when I say to people, you're in a meeting, your boss comes out with a new initiative, you disagree with it, and you say something, everybody looks at you and thinks, and the entire audience always responds, I'm not a team player. What is culture? Culture is everybody knows it, nobody talks about it, and it's not written down anywhere. More powerful than anything else. So in summary, it's important, if we're going to change a culture, to know what the current culture is and to recognize that it's fear-based, and all of these descriptors that I have in the next slide. And also to realize that, the vast majority of caregivers that we work with are fantastic. But as Dr. Phelps says, as long as there's just one person that doesn't play by the rules or do their fair share, then we can't have trust, which is the foundation of every single solitary team. In all the natural disasters, there's one common denominator, and that somebody always knew. There were 5 first officers, for example, on the Costa Concordia that knew and were aware and could have interacted, but they didn't. We know in hospitals, too, because when I look at the audiences and say, especially if I'm talking to boards or senior leadership, it doesn't matter actually which level it is, I'll say, how many of you have received the phone call that says, I just want to give you a heads up that the wife of the board member is coming into the hospital, or Dr. So-and-so's wife is going to be on your unit today? That is an example of people at the top that know that the culture is not safe. And another example is knowing that we can't and we don't give our loved ones to just anybody on the floor. When we can say yes to that question, when we can say on every unit and every hospital and every organization, yes, anybody can take care of my loved one, then our patients will be safe. So to quote Dupree, the first accountability of a leader is to know reality. And I propose to you that that's where we fail. We just don't understand the culture that we're in because we're working so hard and we're in it. And the job of the board, at the board level, the job of management, the job of even the frontline staff, everyone, is to make harm visible and personal. I was asked to speak at one organization where 6 patients had died in the last year. I rounded throughout the hospital. 2 of them I knew had died because of complications after falls. There were 29 fall signs posted on a 32-bed unit. The staffing ratio was at only the 25th percentile. It wasn't humanly possible for anybody to take care of 15 patients. But if we're going to get at the bedside and ask what the nurses' everyday world is like, I think it's important to understand that as human beings, we don't understand when we're asked to do more with less constantly. When we look at the research, what we find out just looking at the practice is that this is an incredibly task-oriented environment. In fact, what it reminds me of is Lucille Ball putting the bonbons in the conveyor belt into her mouth over and over and over again. So in this type of environment where nurses are overwhelmed with the amount of tasks, that no task takes longer than 3 minutes, that they have over 160, that they have 7 to 10 stacking items, that they don't have any time for reflection and delegation, we can't ask people to stop and think. They become more like animals. So looking at the definition of compression complexity, and you have in a bibliography at the end of this many articles that will support this, to take this up to understand the culture that we're asking people to practice in. Today I just covered the practice issues, then we can add all the rest of them, and the result is that we must change our very power structure in organizations from the hierarchy to a team where everyone is on board with what is best for the patient. And let me just finish with what some strong leaders are doing. First of all, they're making sure that there's only one priority, not money and finance, and the patient, but the patient. There's number one priority. They ask for feedback. They measure communication competency. They create a sense of urgency. They genuinely care about the patients. They encourage diverse opinions, hire for values. And when they create this community of people who care, I think that the synergy is there and the table is set for our patients to be safe.
Thank you very much, Kathleen. Just fantastic. And again, you know, the crisis is still there. Everything that we have talked about over the last 4 or 5 years are the same issues. When we started with the NQF safe practices, these were the same issues. And it always came around to you have to make a choice between money and doing the right thing. And what I would really am hopeful that you all are impressed with is Dr. Williams, and he actually was leading a rural hospital that was under much more financial pressure than most of the organizations that I know. They had an enormous financial crushing pressure. They were losing patients to the larger centers. They, in fact, were being required to send money back to CMS because they were 2 miles too close to the other rural hospitals. So you've got financial pressure. There was a really difficult time working with the docs, and they were ranked below 4,000 of 5,000 hospitals in major areas. And so with these financial pressures, in spite of these financial pressures, they went to number 1 according to CMS, and it was not by spending money. So I think this is the redeeming story of what leaders and what great leaders can do, and that we don't have to trade profit for patients, and that really by focusing on leadership, there's an enormous opportunity here for all of us. And I think we need to tell these kinds of stories about groups like theirs that did this, knowing that this crisis is getting worse nationally in the boardroom and at the bedside. Dr. Williams is actually in a board meeting in Dallas-Fort Worth and took the time this week actually to record this with me. And so we're going to play that discussion as a presentation to you. Go ahead, Kyle, please. Dr. Williams, you have an incredible background as a physician, as a leader of healthcare organizations, and now higher ed. Is it really true that we have a crisis in the nation, in the boardroom, and at the bedside?
Yes, it is true. It's true both in healthcare and both in higher ed. I see it in both places. But especially in healthcare, which is what we're focused on today, it's occurring at all those levels. But I come back to it's especially occurring in the areas of leadership.
So tell us about the Fredericksburg Memorial Hospital story.
So when I was practicing at Fredericksburg, I had the opportunity a few years earlier to sit in an audience and hear Dr. Berwick speak of the escape fire story. And that got me very tuned in to the patient safety issue across our country. And then a few years later, I got the opportunity to become the CEO of the hospital and implemented some patient safety initiatives and was surprised at how much pushback I got in the hospital environment. And continued to have that conversation with our team, and then we ultimately led to showing them the Chasing Zero movie, which quickly got them aware of how desperate this situation was. We showed the Chasing Zero to our board, and then we rallied our team around an opportunity to improve. Subsequent to that, we had a 13-year-old boy, Quinn, who came to our emergency room. And ultimately, Quinn died as a result of some congenital anomalies. But ultimately, we treated their family horribly. And we learned many lessons about how we can improve better. And we did not help Quinn and his family have an opportunity to have a good outcome by the way we treated them. So we used Quinn as a rally call as to how, and his family became involved with us in turning our hospital around to be a leader in being safe and treating families as a center of care.
We have an amazing set of accolades. Top 10 finalists for Malcolm Baldrige National Presidential Quality Award. You won the Malcolm Baldrige National Best Practice for Leadership. Proven top 100 U.S. hospitals for 2012 and 2013. Recognized by CMS as the #1 hospital in Texas, the #1 in the U.S. for patient experience in the last quarter of 2012. Top 5% in U.S. Patient Quality, Patient Safety Award. It goes on and on. Leapfrog, you won an A, the Texas Hospital Association Award for 2011 and 2012, and Health Grades and Texas Quality Awards of other kinds. This is an amazing set of accolades, and yet you were ranked below 4,000 and had this turnaround in the face of incredible financial pressure. This was not a wealthy hospital that came out of nowhere with these great accolades. How did this happen?
It happened because we took the time to put a great team together, and we rallied around a vision of creating remarkable care for all of our loved ones and our neighbors. And ultimately, I think it really came to the team understanding that, and me as well, that we were nothing more than mediocre. And mediocre hurts and kills people. And so we made the conscious decision to rally around a new vision, and we set our sights on the top decile of hospitals in the country. We're using Press Ganey data and other data we could find. And those were, even though they weren't in our division of small hospitals, we continued to want to play with those bigger places that had resources that we would never have. So we focused on what changes could we make at the bedside, in the boardroom, with our team that cost next to nothing. It was mostly just human-to-human effort.
And so that's incredible. And you were a practicing physician at that hospital earlier,
right.
And when you were a doctor and you brought in the escape fire story to a prior leader, they blew you off.
Right, they did. They really weren't interested in hearing the story of the escape fire or even addressing or talking about patient safety as even a major issue.
So the next thing you know, you're the CEO of that same hospital under enormous financial pressure and having to actually give money back to CMS.
Right.
And at the same time, focusing on patient safety and quality, because I know our audience that we reach out in our national research test bed are facing the same doggone things, enormous cost pressures and having to do more with less.
We as a small rural hospital and a sole community hospital, we're struggling, and we're struggling to make a margin every every year. But we focused on doing the right things at the right time with the right people, and we had a team dedicated to that. And that's what turned the whole thing around. It wasn't anything I did except just as a leader to try to focus our team on the vision that we could do this. And it wouldn't cost money. And then we got our board engaged, and they understood the plight we were in. And we talked to them about an opportunity to use this as a differentiator for us against other hospitals, because we knew that there weren't many hospitals focused on these issues.
So what's your message to those national leaders that know we're in crisis, those leaders in the boardroom and those at the bedside? Because we've got that audience in the group that are listening to you.
First of all, I think they have to understand that as a leader we have to take personal accountability. We have to understand that every one of us are patients at some point in time, and even now or in the future. And if we don't address this problem, ultimately we and our families will be affected, friends of ours will be affected. And so what I would say as leaders is, first of all, take an assessment around your leadership team and understand, first of all, do you have values that you're all aligned with? And then what are your personal values, and are those personal values shared by the whole team? And are they correlated in a way that where you can focus on one vision? But if you don't have a leadership team that focuses on the same set of values, you can't address these hard problems.
We love practical and tactical things that we can give to our audience that they can run with. Give us the capsule on your hero book.
So every Friday or every day, we gather our team for a huddle every morning, and typically Monday through Thursday that huddle is around getting the day done and focusing on our priorities. Friday is a special day because it's called our hero huddle, and all of us have a red moleskin notebook that we carry, and we bring that to the Friday huddle. And in that huddle, we go around the room, and every executive team member gives the name of someone across the entire campus that they've seen going above and beyond, taking care of our students, taking care of our patients, taking care of each other, or even a community member. What have they done that's above and beyond? And we recognize that person. Then we pick a volunteer from the executive team to go talk to that person, explain that they were nominated and that they were set up as a hero for the entire campus. And we give them a letter ultimately. And we've seen our frontline team members put those letters up on their walls, share them with their families, and it's created an environment where people love being recognized. They want to be a hero.
And it doesn't cost anything.
It doesn't cost anything. The cost of a letter, piece of paper, nothing.
So now you're leading one of our major educational centers, and actually you're producing the number 2 number of primary care physicians in our country. So you're really having a major impact. And you have 2,000 people that are responsible for teaching 2,000 people, and 5 schools and 10 degree programs. What are you doing from what you've learned to help us with this crisis that we've got nationally?
Well, one thing I would also add to what you said, Chuck, is we also have the opportunity in our clinical practice to see almost 550,000 to 600,000 patients a year. So we have that piece as well. And I think because of the diverse population of the Health Science Center, we had to come back to the center and we had to say, what are we as a community going to be? What are we going to be defined by? And we started off by defining what our team values were. And we brought our frontline team, we brought community members. We went through a process where and out of our whole population, we had over 800 people participate in a survey around values. They gave us their values. We aligned those, and we came up with our top 5 values. And with those values, then we put behaviors with each value. And then we set up trust as the final 6th value, if you will. And we see these values as, if you will, the piers or the rebar that goes into the foundation of the cultural transformation we're building. Because we want this culture to withstand pressure for years to come and be sustainable leader after leader after leader. And so it had to come to what are the values of the team, not my values. And so that's what's going to be the changing force for us.
Well, congratulations on being able to do it in probably the toughest place in the world, which is where our audience lives, out there at the front line, enormous financial pressures and not having any financial resources to call on, and you've been able to actually win in the game. It really seems to require a lot of resources, and now applying it to education. Thanks for the inspiration.
Thank you, Chuck. I appreciate the opportunity, and I want to appreciate all those in the audience and what they do every day, taking care of patients better.
So in summary, Dr. Williams, a board-certified critical care doctor, an anesthesiologist, was a practicing doc like so many of our caregivers at the front line, couldn't get through to the C-suite, found himself the CEO of that hospital, and was able to take it from below 4,000 to #1, and got a call out of the blue from CMS and was told that they were #1 in the country. And what did they do? They benchmarked the top 10% regardless of category. They didn't try to be above average. They tried to be better than the top 10%. And it didn't cost them any extra money because they made it part of what they did, but they engaged the board and the docs and made it a crisis. And it became a leading through crisis issue because they had to make patient safety an intrinsic property of their own survival. And Dr. Williams was rewarded with now leading one of our major teaching organizations. So I'd like to shift gears now and ask Terry Wheat, our reactor, to what she's heard from Tom and John and Kathleen and from Mike most recently, and she serves as the Director of Patient Care Services, and everybody who touches patients reports up to her at Shriners Hospital for Children in Chicago. She's also been a board member of Sinai Health Systems, and we're so blessed and thank God that she was brought to us by Sharon Rossmark, who said, look, she is terrific, she's got great insights, she's got the bedside, she's got the boardroom, she's got vision, and she has faith that we can do this right. So Terry, can you react to what you heard and give us your message?
Well, good afternoon, and thank you. It is different when you are reporting to a board and then being on a board and having the information reported to you. And so being at Shriners, which is a smaller hospital, I take what Tom and John and Kathleen and Mike said very seriously. And in a nutshell, the transparency that the board needs to have is so important. And there needs to be trust that has to be established between the board and the CEO. Because truly, as the speakers have said, the buck stops with the board. And so if the board is not aware of what's going on, they can give you all the money they have and donate. But when a patient is in crisis or there's a travesty that happens, the board is responsible for that hospital. And I think the board education has to not just happen once, but it has to be on a continuous basis. It has to be a yearly thing. And I think the leaders in the C-suite have a responsibility to make sure that the board understands and knows the regulations that are coming out that are new and different and how it impacts the hospital. In addition to that, when Mike, doctor, talked about knowing the huddle, the Friday huddle, you can't have a Friday huddle and talk about a hero unless you're out of your office and you're doing management by walking around.
Absolutely.
So I truly commend them on that. The culture, you should not have a culture of fear. And I guess one of the questions that I would ask is to ask the board members, would you receive your care at the hospital you're on board? And if the answer is no, then we have a problem. So those are my thoughts right off the top of my head.
Well, thank you, and we're going to come back to you, Terry, and I really appreciate your thoughtfulness and being somebody with responsibilities at the bedside and reporting to a board, and then being a board member of another hospital is a pretty unique perspective and a really a great one. Before I go back to our speakers, I just want to let you know that we are moving forward with a Leading Through Crisis training program. And what we'd like to do is find out if you're interested, would you like a training certification course on leading through crisis? This would be if you had a patient safety accident, a personal crisis, a crisis of conflict of interest. What do you do about care of the caregiver after bad event occurs? And then also, how do you talk to the board about the impending crisis that we have in safety when they are being distracted by so many other things like perceived financial survival issues that they think are not related to patient safety? How to brief the board and how to be able to engage them. So we'd like to know on a scale of 1 to 10, do you very strongly agree that this would be of value to you on a 1 to 10? the second question is, does your organization have a crisis rapid response team? And I want to make sure that everybody understands this isn't a rapid response team for the patient that needs to be resuscitated or is at risk, and we're calling to have a team come and take care of them. We're talking about an institutional crisis. For instance, if you had patients in your institution, like in Indianapolis, when all of the administrators were being paged because they had deaths of babies and they had a real crisis and nobody knew what was going on and everyone was called back to the hospital. Does your organization have a rapid response team to a natural disaster, unnatural disaster, and more specifically, a patient safety disaster, because there are different problems. And we'd like to know a crisis rapid response team that isn't just your response to a hurricane. We're talking about the kind of patient safety and quality issues that we've addressed. Would you like a mini documentary on leading through crisis is the third question, 1 to 10. If you could have a 10-minute or a 20-minute video that could help get the message into the boardroom about the topics we've discussed, but a lot more practical, okay, now here's what we're going to do because we have these barriers. And then the final two questions are, and you all have been so great over the years, and we calculated it, we've delivered over 104,000 learner hours, we estimate, over the last just 6 years, and a low of probably 34,000 if there was only one person per line. But you've always been great about giving us information that could help you or help us help you. What would you like to learn about leading through crisis? We want to make sure it's what you want, not what we think you want, and what you think you know or you really feel a need for. And then the second question is, what types of crises are you worried about that are keeping you up at night that might happen to you that happen somewhere else? Is it the widespread infections in the procedure labs? Is it misdiagnosis? Is it overuse, underuse, misuse? So if you could put those in the lower right-hand corner of your screen, it would help us immeasurably as we build this course and really address these crises that we know are happening, and we know that our employers are going to start asking us about. What are you doing about overuse, underuse, misuse? What are you doing about misdiagnosis? Do you have a system to make sure that you're not making the errors that Tom had addressed? Because these are employers that are becoming informed. So I'm going to go back to Tom and ask Tom to kind of react to what he heard today. We started out with the crises, but then you heard from Mike Williams that here's a guy that took a hospital in financial distress, focused on patient safety, and then pegged the needle without having to spend an enormous amount of capital.
Well, thanks, Dr. Denham. My first comment would be about Dr. Williams. He described a perfect model of transforming a hospital to from an also-ran to a leadership position. And that's the exact type of hospital. Well, let me back up a bit. That's the perfect model for conversion, what he described. And I can't praise what he did there enough. That's the exact type of facility that Hill Country Memorial, that employers are looking to send their patients to. They're paying for their travel, they're paying for the lodging for them and a companion to get the right care, the right treatment, the right diagnosis, and deliver care that's ethical in the way I described. On the other hand, I'm deeply, deeply troubled by facilities that say they don't have the budget to fund patient safety. I think they're living in the past. Historically, hospitals, if there's been a nosocomial infection with a patient or an unhappy event, the hospitals historically have made more profit from that. I mean, they can't divert some energy to patient safety and preventing these things. Their future looks pretty bleak. What will happen with them is they'll see an ever-increasing percentage of their patients being Medicare and Medicaid patients, and a smaller percentage are going to be good-paying private patients. Now, I'm working with Medicaid in a state, and interestingly, the Medicaid population isn't nearly the outliers and that aren't nearly as overtreated as the private pay patients at hospitals. Well, the only reason I can assume is the reimbursement's too low. But what John described, Kathleen described, are perfect models for how the change need to be implemented through leadership. The first step in that is they have to make a decision that they want to improve. If they don't make that decision, whoa, what's happening to them, and many of them aren't aware of it now, but they're losing some of their private pay patients to companies like Walmart, Lowe's, Pacific Business Group on Health members, et cetera. Large numbers of companies are now taking patients away from those places and sending them somewhere else for the kind of care that we know they should be having, the kind of care that Dr. Williams was able to implement in his facility. Every hospital in America is losing patients, good paying patients, with good private coverage to places like what Dr. Williams described. That you can't address this stuff soon enough. I've done work with some hospitals on advising them on how to convert from a model with the lower ethical standards one with higher ethical standards. I mean, they're got to get the diagnosis right. They're going to get the treatment plan right. Some have been very successful. Others haven't because they really were addicted financially to excessive surgery. One last comment. I was at a conference recently named Cracking Health Costs, a symposium which is named after my book. I was very flattered about that. But there was a speaker there from a state hospital association, and during the Q&A, somebody asked him, do the hospitals in your state, do they do a lot of unnecessary surgery? And he said, well, of course they do. How else are they going to keep the patient beds filled? You could have heard a pin drop in the audience. I mean, people were stunned that he would admit that publicly. What he was saying was, the connotation of what he said was, this is so common in healthcare that he wasn't embarrassed to admit that publicly in front of an audience of payers. Every one of those payers came up to me and said, did you hear what the guy said? Not everyone, but half dozen companies, did you hear what the guy said? And I said, yeah, that's the problem. Now, that is creating an enormous safety risk for hospitals and a risk in terms of losing. If you want to have a higher mix of Medicaid patients, that's exactly, they do what he's doing, what that association is doing, not the other.
These are great insights, and I think the urgency, your comments are really driving home the recognition that that the hospitals are no longer dancing in the dark, and the spotlight's going on. John, and then Kathleen, do you want to react to what you've heard, what you've said, and to Mike's story?
Can you hear me, Chuck? I'm not sure.
Yes, sir.
I'm not sure anybody can hear me.
Yes, sir.
Okay. I'm sitting on an airplane right now. Where else would I be? So I got to keep this very brief. But basically, I think what we've all said here is an omnibus basic early warning. That's not too early anymore. That we have got to all pull together to get this alarm sounded, because we've got too many people wandering around in a fog, not believing that this is a major crisis. You know, I have a lot of people who think that the Affordable Care Act is some sort of a political football one way or another. And I keep trying to explain to them that's the last best chance to avoid future nationalization. We better get off our duffs here and get this clearly enunciated, that patient safety has got to be paramount, or the reaction of the body politic, as uneducated as they really are about healthcare matters, when they find out what we already know, it's going to be fearsome, and of course that will translate to congressional action, and of course that will be too little too late and off the target. So I couldn't say this enough. This is like looking at the dichotomy between crashing 3 747s per day, which is what we're doing essentially in the same numbers in healthcare and people we kill, and the fact that we wouldn't have an aviation industry inside of 5 days. It is absolutely absurd that we can't get the body politic to understand this, and we can't get our own institutions to move faster.
Thank you, John. Absolutely. And by the way, I just calculated for another paper, the latest number for a 747 of full passengers is 416. We've got 21 of them going down every week now. We used to use that calculation with 75% capacity. We can now tell people it's a fully loaded 747, 20 of them going down a week. Kathleen, would you like to comment?
Thank you. First of all, I hope John's not on a 747. Second of all, transparency around outcomes and cost is going to be followed by transparency about harm. very, very quickly. As we know, as CMS just reversed their decision last week. And I think that people like Mike who are doing the right thing, recognizing that leadership is the way to pave the way, are going to be in the lead. And we don't have any time to wait. We need leadership yesterday, and leadership is not about keeping your job. It's about doing the right thing, saying what you see, and making the patient the top priority in every conversation.
Thank you. Terry. And then
Yes.
we're going to go to questions. We have a few minutes for questions that you all may want to ask of Tom and even including Terry. So there's a Q&A panel at the low on the right side of your screen. If you have a question that you'd like to ask, please do so. Go ahead, Terry.
Well, I just wanted to just summarize again and say that it's very important that we educate board members. The other thing is, things that are important to us is what we measure. If it's not important, we don't measure it. And so I know for our board, we look at quality first on our agenda and the finances after that. So we have to be careful how we measure and what we bring to the board. I think we all have a stake in making sure that we do the right thing and we do the right thing right.
Great. And so we've got a question, two questions, actually from Dan Ford, one of our longtime patient advocates nationally. He'd like to ask you all to react to, why don't we ask more patients and families to play roles in those issues that we discussed today's first question? And since we're short of time, I'm going to ask a second question because I'd love to hear what you all think. What is the caliber of the CEOs across the industry, of the hospital CEOs we see today, those that we're interacting with? And John, you're on the plane. I don't know if you have another minute, but you're interacting a ton with these hospital CEOs, and you're talking to them about getting patients and families in. Let's start with John, if he's still on.
Well, I think the vast majority of our CEOs are incredibly well-meaning people, but many times they're deer in the headlights, and they are trained not to show it, because they've got so many competing interests that they still think, when you scratch most of them deeply enough, that their job is to keep the doctors happy. Well, we want our doctors happy, we want them leaders, but that is not the focal point of patient-centered care, which is the basic foundation of safe care. So one of the problems is we have got an awful lot of leaders in the C-suite who are trying their best, but they really are confused as to what's needed, what the priorities are, and this is why boards, as I'm saying, need to step in and say, your priority is, number one, don't hurt anybody, and number two, build this system for the surrounding community that you're pledged to serve. Everything else has to fall by the wayside.
Great, thank you. And I'll go to Tom. I just wanted to get John just in case he had to be had to break before the end. Tom, two questions. One is, would you like to see more patients and families in the boardroom and actively involved so we can turn the quality spotlight on, number one? And number two, what is your impression of the caliber of the typical CEOs out there leading hospitals and health systems?
Well, I think patients are inevitably going to get more active in this, but it's not going to be in a happy way. I think they've got to get more active in terms of litigation when they find out that somebody died from a procedure that should never have happened in the first place. In fact, in the news today, a doctor in Michigan pled guilty on diagnosing patients with cancer and treating them for cancer when they did not have cancer. And he's facing a 128-year prison sentence for that. Now, for that to go on, a similar thing happened at Columbia University Medical School. A doctor there confessed, the professor, 20-year professor, confessed to diagnosing 80% of his patients with heart disease and treating them for heart disease when, in fact, they did not have coronary artery disease. He's going to jail for 5 years. This is that kind of a stain on a hospital is the worst thing that can happen to them. I mean, absolutely the worst kind of stain. And that is an enormous risk. It's time to step forward and no longer accept the status quo, but begin changing it. And it's entirely possible to do that. Every safety leader in the audience, I'll address this comment to them, it can happen and can be done. An interesting side effect of this is the ones that do it right are getting more patients. They're probably doing more surgery, by not doing unnecessary surgery, because the denominator is so much bigger.
Right. Kathleen, typical CEOs, and why not more patients and families involved and engaged on committees and teams?
I'm going to have to get back to my PowerPoint, which is that they don't know the reality on the front line. And to echo John, it's not because they're bad people or even with bad intentions. It's because they're human beings. And what we know from behavioral economics is that, you know, when you work very, very hard at something, when you pour your heart and soul into it, you have a tendency to see what you want to see. You see the results that you want to see. So the first conversation I always have with any executive senior leader, they're always telling me how many awards they won, and then after that, it's how much money they saved. And I keep asking the same question, but don't tell me that information without how many people you've harmed, you know, and they compartmentalize. Then I think that we're all busier than ever. We've all been, healthcare is so complex, and this busyness results in not meaningful rounding. They're rounding, but not meaningful conversations. A lot of them put that at the bottom, and it's a pro forma, but they don't really want to know what's going on at the bottom, because if they did, there'd have to be a lot of changes.
Well, listen, I will close by I put the slide up regarding this triple healthcare crisis, this burden that we're experiencing, the employer crisis of direct and indirect costs. The direct costs are the dollars out of pocket, leading cause of bankruptcy of folks in the middle class, the enormous indirect cost of presenteeism and absenteeism and lost productivity, the provider crisis because everybody is scrambling to build their networks and try to move from volume to value again, which is a repeat performance of the last couple of decades, and letting safety drop out of the top of the list. And then what Mike is experiencing now is that he's running schools that are training caregivers for the old model, and yet all of the licensure and accreditation organizations are still measuring them against the old model where safety and quality are not an intrinsic property. So we're going to be addressing these crises as we go forward, and we'd like to thank all of our wonderful speakers and have them stay on if they can, just so we can do a good process improvement loop. And we'd like to thank all of you for attending, and we'd like to have Becky Martins close us, because in the end, it really is about us serving these patients and families who are entrusted to our care, that sacred trust that John had mentioned. Kyle, please roll Becky.
Well, I'll leave you with a couple of words of affirmation, because I'd like everyone to go back to their work day encouraged. Everyone has a role to play, is what we heard earlier today. And most of all, to be on the direct caregiver line of action every single day. A lot of patients and families will never understand or comprehend how much effort has gone into that. So my words of affirmation are this. When you're near the end of your workday, and as you're walking out the door, you ask yourself, have I made a difference today? When you have the right people doing the right things, you get the right results for your patients. You have made a difference. The result, today at your hospital, someone is bringing their everything home. What does that mean for patients and families? It means that our families remain intact. Birthday candles will be blown out. High school graduations will be attended. There will be dance recitals, home runs, new marriages, new babies, and presents to be unwrapped. That's all to be celebrated in a direct correlation to the work that everyone is doing to advance safer care.
So thank you all for attending. And our next webinar, we're going to have Dr. Mike Henderson addressing the new role and the critical role for safety and quality officers. And he'll describe the Cleveland Clinic journey from where they are or where they've been to where they are as one of our top organizations in safety and quality. So thank you, and that ends our webinar today.